Good afternoon, everyone, and welcome to this recall session on dermatology. So I hope
Good afternoon, everyone, and welcome to this.
I hope your exam went well yesterday. And as far as dermatology is concerned, I think the questions were pretty straightforward and easy. And I'm sure you must have cracked most of your questions pretty well. And you will come out of it through flying colors. My best wishes for that, first of all. And now coming to the session where we would be basically discussing the recall questions. These are the questions which you guys have told us and which we've collected from here and there. They may not be the actual questions I asked in the exam. Maybe the framing of question was different or the options were different. So this session is more for you to help me out frame the right questions and discuss what you did. Okay. So again, don't start marking yourself, as I always say, based on this session, because maybe the question was different, the option was different. So just enjoy the session and help me out with the options here. So starting with the first question that I have, a 25-year-old male presents with asymptomatic symmetrical scaly lesions, which are shown in the image, and you had to identify the pattern. So if we look at the options and we look at the image, so probably an image was provided to you where there were red scaly lesions on the trunk, and they were typically along the tension lines of the skin. So typically called as Christmas tree pattern. And we all know that Christmas tree pattern is seen in pityriasis rosea. So I'm not sure whether they had asked you to identify the diagnosis or the type of pattern of scaling, but whatever it was, even if something like this, an image was given, or there was an image with a herald patch, you would have figured out that this is the Christmas tree pattern. So the pattern, if they had asked you, it would be a Christmas tree pattern. If they had asked you the type of scaling, it would be collarette scale. The collarette is typical collar-like scale or scale on the periphery of the lesion. And these are both features of pityriasis rosea. So if there was any confusion with this question, I would request you to put in the chat box so that we can discuss. Otherwise, it was a straightforward question. Lichen planus has Wickham's tri, in which there would be a mineral oil and a hand lens. And Christmas tree pattern is not seen in lichen planus, and Warnoff-Ring is not seen in sebum. So in the back, if it was given, you might confuse it with seborrheic dermatitis, but seborrheic dermatitis presents with Brany scales, right? Warnoff-Rings is a feature of psoriasis. So since there are no inputs, I guess this was the question, quite straightforward. So we move on to the next question. A patient came to the OPD with complaint of pain in the genital area. And on examination, you noticed painful coalescing vesicles associated with painful lymphadenopathy. So either the diagnosis was asked or you were asked the causative organism. Again, pretty clear, no confusion. Pain in the genital area, coalescing vesicle. If there was a term coalescing vesicle in the question, you know we are dealing with herpes simplex virus, because only this virus leads to coalescing vesicles. Especially herpes genitalis will present in the genital area with pain, with painful lymphadenopathy and coalescing vesicles. So the diagnosis here becomes herpes genitalis, and the causative organism we all know is HSV or herpes simplex virus 2. The other options, molluscum and human papilloma virus, are never painful. They are painless lesions. Varicella zoster virus, if they want to give you, they'll give you a dermatomal distribution and they will not give you this painful coalescing vesicles. So here again, the question and both the answers were straightforward, and HSV2 would be the answer here. But again, I would encourage all of you to give me more options, or in the question, if you think there was anything different, kindly put it in the chat box so that we can discuss it further. The third question was, what is the cause of non-scarring alopecia from the following option? So they had given you some options and asked you non-scarring alopecia or alopecia which does not lead to scarring or is non-cicatricial in nature. Now, non-cicatricial alopecia can be of various types. Let's look at the options here. Alopecia areata is a non-scarring alopecia. Telogen effluvium is a non-scarring alopecia. Androgenetic alopecia is a non-scarring alopecia. Now, the confusion was with tinea capitis. Tinea capitis can cause both non-scarring and scarring alopecia. So here, the answer would depend on the options which have been given. Now, if I look at the option, I do not have any option of all four. If there was an option of all four, I would have marked that. But since there is no option of all four, I consider that probably the examiner is talking about scarring kind of tinea capitis. And so I will mark option B or option 1, 2, 3. Or if the question was, which of the following is not a cause of non-scarring alopecia? And again, if these were the options, you would mark tinea capitis, because alopecia areata, TE, and androgenetic alopecia are strictly non-scarring alopecia. Okay, it was non-scarring. Very good. So there are a few more inputs. We'll discuss about them based on what questions do we see. But and also, yes, so someone was telling me one of the options was probably lichen planus also. If that was there in the option, that is definitely a scarring form of alopecia, right? So one of the options was scarring. It was non-scarring. Okay, fine. Great. So I think we are on the same page, more or less. The next question was, a 60-year-old diabetic patient present with lesion on the nose as shown in the image below. What is the diagnosis? So you were given an image of a plaque which showed raised erythematous margins, which are looking thready, which has telangiectasias, and there is a side central scarring that you see. And the lesion is present on the nose. So what is the probable answer for this one? Again, very, very straightforward. We had shown you this image multiple times. Presence on the nose. This is basal cell carcinoma or BCC, right? You might get confused with DLE, but DLE has 3 zones. DLE can also happen on the nose, but it has 3 zones typically. This one shows thready margins, thready elevated margins with telangiectasias. This is nothing but BCC, unless obviously there was something more. So, okay. So for the previous question, you're telling me, Faiz, that tinea capitis was not the option. Probably lichen planus was the option. Then your job becomes much easier because you all know that lichen planus is the scarring alopecia there. Thank you so much. So hope this is clear to you. I'll move on to the next question. Where is the apocrine gland present? So apocrine gland, we all know, is a type of sweat gland, right? So sweat glands are of 2 types, eccrine and apocrine glands. While eccrine glands are present all over the body and are predominantly concentrated on face and palms and soles, apocrine gland are predominantly present in axilla, in the memory area, or in the groins. So if they had asked you apocrine gland specifically, and these were the options, the answer would be axilla, right? Palms and soles, face and scalp are the areas where mainly eccrine gland is present. And that is why you sweat on that area more. Apocrine gland is present on the axilla. So again, a very, very straightforward question, and answer would be axilla. So I am waiting for your inputs. In case there are more options, you can talk about them in the chat box. The next question was, an immunocompromised patient presents with following lesion on the tongue. What is the probable diagnosis? So when I look at the tongue, I see some whitish adherent plaques which are present on the tongue. And in the question, I've been told that the patient is immunocompromised. So here, my answer would be leukoplakia. Any white patch for which a cause has not been determined, especially in an immunocompromised individual, think of leukoplakia. Now, if in the option oral thrush was also given, then it might get confusing. But I don't think so that was the option here. So based on the option, this is not lichen planus. Lichen planus would have presented with more purplish looking plaques, atrophic looking plaques, not white raised plaques. Or oral keratosis, which would also present with slightly raised lesions, not like these adherent whitish plaques on the tongue. So if this was the question, approximately this was the image, answer here would be leukoplakia. Right? So we move on to the next question. 13-year-old patient presents with velvety lesion as shown in the image. What is the diagnosis? Now, here I am not sure if these were the options given to you. Now, the diagnosis here, if they have asked you diagnosis, it would be acanthosis nigricans. The diagnosis here is acanthosis nigricans. Now, acanthosis nigricans is seen with insulin resistance. But again, I would need your help here. Was this the exact question? And was this how it was framed? And were these the exact options? So if this was the question, exact options, then I would say acanthosis nigricans would be the answer. And in the question, if they had asked which condition it is seen or something like that, then both A and B could be marked as the answer. But if they had just asked you the diagnosis, it would be acanthosis nigricans. Now we know that insulin resistance is a very important cause of AN, but there are other causes. We know that AN can happen with OCP use. AN can be a part of malignancy. So there are other causes as well. So diagnosis would be acanthosis nigricans, and one of the causes would be insulin resistance. Okay, so yes, Dr. Hilol is telling me that this was not the exact question. I also think so. They would not confuse you like that. So something which was related to acanthosis nigricans, if you can help me out with the actual question, that would be great. Now, these are the questions that I have for dermatology. If there were any more questions, I would want you to put it in the chat box so that we can discuss them. So someone had said, Dr. Kavya, that there was a question that a mother infected during pregnancy and now child has vesicular lesion on upper limb and thorax. Okay, so probably what Dr. Kavya is trying to tell is that the question which was related to HSV or herpes simplex virus, the options were different, the question was different, or maybe they were two different questions. So mother infected during pregnancy with what? Had they given you something? Can you give me more clarity on that question? So anyways, even if this was the question and mother was infected during pregnancy and now child has vesicular lesions on the limbs and thorax, it would be congenital varicella. It can be congenital varicella or congenital herpes. So all depends on what was given to you in the option. So if it was given that mother had herpes genitalis during pregnancy and now the child is born with vesicular lesions, then it would be again HSV. Okay, Dr. Hilol is saying that there was a question about pemphigus vulgaris and bullous pemphigoid. Thank you so much. Can you give me a little more detail about that question, where they had given you a histopathological image? So if they had given you a histopathological image, they were probably trying to find out in the image, they must have shown you a split which was either subcorneal, suprabasal, or subepidermal. So if they had asked vulgaris and pemphigoid, so probably they had given you a split, which was their subepidermal. So where you would have seen a complete epidermis on the top, epidermis below, in which case bullous pemphigoid would be the answer, or a split which is happening in the epidermis, in which case pemphigus would be the answer. Right? Perfect. So yes, there was a split which was present. So if the split was present, based on the level of split, I'm sure you would have answered that question. So was this the question, Dr. Hilol, that they'd given me a slit and asked you what can be the probable diagnosis? And the options would be pemphigus vulgaris, bullous pemphigoid, and maybe dermatitis herpetiformis or something like that. Right. So the split was present below epidermis and you have to make a diagnosis. So then the answer would be bullous pemphigoid. Right. Okay, so thank you for your input. Any more questions or any more inputs on the questions that we have already discussed? I would wait for a few minutes for you to put it in the chat box before we wind up the dermatology recall session. So I think the questions were pretty straightforward, and I'm sure you would have marked all these questions right. I don't think so that there was any confusion or any choice options which were difficult here. They were pretty straightforward, straight out of the book. The images that were given were some things which we have discussed n number of times in our revision sessions, in our actual sessions. So any more inputs, everyone, before we wind up the session? If there was any more question that you can recall. Okay, so Dr. Hilol is telling me there was a question which was having a immunohistochemical image. So immunohistochemical image related to what, if you can point out more? Was it immunohistochemical or was it direct immunofluorescence or something? If you can give me an exact question there. Direct immunofluorescence. So probably it must be the same question about immunobullous disorder. You were probably given a split and a DIF image where basement membrane would have shown fluorescence, again pointing towards bullous pemphigoid. Or it were two different questions. One was on histopath image and one was on the immunofluorescence. Okay, so there was a question only on direct immunofluorescence. They had asked you what is the gold standard test for immunobullous disorders, or there was some other question. So two different questions. Okay, so there was one question on direct immunofluorescence and one question on histopathology. And in DIF, Dr. Hustling, if you can tell me what was the exact question? So I think we covered most of the questions since I'm not getting any more inputs from you. So probably most of the questions have been covered. And the another possibility is that, yes, we might have missed on the histopathology and DIF question, which you're telling me. Okay, so what is used for detecting autoantibodies? Okay. So what is, so the question was probably what is used for detecting autoantibodies. So something similar. So probably they were asking you about direct and indirect immunofluorescence. Now, you know, in direct immunofluorescence, I'll just explain so that whatever the question was, it would be easier for you. So in direct immunofluorescence, we have a antigen antibody complex on the sample itself, and you give antibody immunoglobulin, and that settles, fluoresces, and that shows as antigen antibody deposition in the tissue sample. Whereas in indirect immunofluorescence, you detect autoantibodies in the blood of the patient, right? So if they wanted to ask whether autoantibodies were present, then it would be indirect immunofluorescence because autoantibodies are detected in the blood, right? Something similar, probably, yes. So they must have asked you the basic principle of direct and indirect immunofluorescence. So you know that direct immunofluorescence, the sample is the affected patient's skin where antigen antibody complex is already present. And if you were to detect autoantibodies in the serum, you would do indirect immunofluorescence, right? So I think that pretty much winds up the dermatology recall questions. I would thank you again for helping me out there and giving me more questions which I was not aware about. And again, wishing you all the best for your results. And I'm sure you would have done wonderfully there. So I'll wind up here and we'll move on to our next session soon.